thank you for logging in tonight to be with us for this session on best fitting techniques for happy patients in a healthy practice with the ICD FlexFit lens. My name is Randy Kojima. This session has been sponsored by Precision Technology and Cardinal Contact Lenses in Canada and ABB Optical Group, the exclusive ICD FlexFit distributor in the US. So the goal today is to share with some of the neophyte scleral lens practitioners how to begin with scleral lenses. And for those of you who are experts in scleral fitting, the idea is to focus the latter half on some more advanced concepts and things that you can do to customize the ICD FlexFit. So let's begin. The design platform has been built to fit virtually any eye shape. So from the most simple normal corneal shape with ocular surface disease, they're pretty much as easy as it gets. But then for the more complex graft patient or irregular corneas, this design was created to be able to manage all of those different conditions. So for many, many years, we've had some options to fit these irregular eyes, corneal GPs being the first and probably the most commonly used platform for the irregular cornea. When we struggled with comfort, we would put that patient into a piggyback platform, and more recently, we've had hybrid as an option. But when these designs aren't working, what did we do? And often we had many patients out there that were struggling with comfort, vision, and the ability to function with some of the platforms and options that we had. And then scleral lenses came along and they really simplified fitting the irregular cornea. There's so many ways that this lens has changed lives for all kinds of patients. So let's talk about which ones benefit the most and how we approach them. The way a vaulting scleral lens like the ICD FlexFit works is to avoid the irregular cornea, the diseased or post-surgical area of the eye, by just vaulting over top, creating a large, deep fluid layer between the back of the lens and the surface of the eye. Then we're going to use the more healthy, the more regular shape bulbar conjunctiva to land the lens in the periphery. So essentially, we're going to avoid the difficult part of the anterior surface, and we're going to use the easier, the more symmetric, the healthier part of the eye to bear the weight of the lens to encourage the centration of the fit and increase comfort. The way comfort is improved with scleral lenses, and hopefully this video makes it easy for you to see, the weight of the lens is entirely on the bulbar conjunctiva, and if you look at the movement with each blink, that lens really shows very little, if any, movement. And that's how a large diameter, rigid contact lens that's thicker than most contact lenses that you might ever fit, that's how it achieves such high comfort levels. A brand new soft lens patient will often report on a comfort scale, a soft lens is a 9 out of 10, and again, that's to a brand new wearer. A scleral patient will usually report that it's somewhere between an 8 and a 9 out of 10 on a comfort scale. So again, we have a large, a thick, a rigid lens that's able to achieve near soft lens comfort, and that's simply because it just doesn't move a lot, generally. Now, the way we provide vision, of course, is using those rigid lens optics, that rigid anterior surface that has that beautiful spherical anterior surface shape. We can mask the irregularity by filling in where the cornea is imperfect in shape and bend light based on that ideal anterior surface shape. So really what's happening underneath the scleral lens matters much less as far as vision goes because you're using, again, the GP optics. So you have the comfort of a soft lens with the vision and optical quality of a corneal GP. And it's really the best of both worlds for the irregular cornea. Now, there's all kinds of application that goes beyond simple keratoconic fitting or post-LASIK, post-radiokeratotomy, transplants. There's all kinds of patients that can benefit from wearing scleral lenses. And in many cases, these lenses are lifesavers to patients that are really struggling with ocular pain. So this is one area that we haven't always thought about contact lenses. Now we're thinking about scleral lenses for some of these very challenging ocular surface issues. Now, in dry eye cases, it's clear that a scleral lens provides what my colleague Lynette Johns calls an eye spa, where we're going to place a lens on eye with this bowl full of saline, preservative-free saline. We're going to bathe the ocular surface disease patient with that fluid, and that creates a whole new level of comfort that often they do not experience any other way. So scleral lenses in the severe dry eye patient has been shown to make a huge difference, and as quoted, significantly improves both vision and comfort for patients who have severe dry eye. And numerous studies have backed this up. This isn't the only three. How about in mild dry eye? And numerous studies have shown that scleral lenses, even for the mildly dry eye patient, can make a difference in the lives of these patients that are struggling with either contact lens-induced dry eye or something a little more severe where there is an underlying dry eye condition. So consider your scleral lenses for more than just the keratoconic patients. Think of them as a tool for your patients struggling with dry eye symptoms. Now, the ICD FlexFit works for all of those kinds of conditions: the irregular cornea, the post-surgical eye, the diseased eye, the ocular surface disease. Within this platform, you have two diameter options in the diagnostic set. You have many different diameters available, but in the diagnostic set, it's a 14/8 smaller diameter lens and a 16/3 lens. Now, when would you use one or the other? And let's go through all that. Now, both designs share a tangent construction. The ICD and the original ICD and the newer ICD FlexFit both share this construction in the periphery that uses straight line or tangent shapes to best align where the eye surface becomes less curved and more tangent. The tangents also allow us to control the parameters of the lens based on angles where the surface of the eye is angular. So as an example, you can see within the central zone of the lens, the cornea, of course, is best defined as a curved surface. But when you get out to the peripheral cornea and the limbus, then onto the bulbar conjunctiva, the ocular surface is best described as a tangent or straight line. And that's what's unique about the ICD FlexFit. It uses tangents where the eye surface is tangent, and it makes it very forgiving. Now, both lenses in the trial set are available in both symmetric landing and toric landing. The 14/8 diagnostic lenses, they come standard as a symmetric landing. In other words, in the trial set, if you pull out a 14/8, the elevation of the landing all the way around is uniform, it's equal. And that's because the closer we get to the limbus, the more symmetric the scleral shape is. However, when you fit a larger diameter lens and you move farther or deeper into the bulbar conjunctiva, then you end up seeing more toric or asymmetric scleral shape. And it's for that reason that the 16/3 uses a toric landing, or what we call a dual depth landing. In other words, one depth of the lens is more shallow than the opposing 90-degree meridian. And that's simply because we're running into more asymmetric surface. Now, there are times when a small diameter lens may be landing on a toric eye. So you can custom order the smaller as a toric or as a dual depth landing. Similarly, with the 16-3, there will be a small percentage, well under 5% of eyes, that you may need a symmetric landing. So both lenses are available either toric or symmetric, but in the diagnostic set, the smaller is symmetric, the larger is dual depth or toric in landing. And there's a reason why the larger is toric. We mentioned that we run into more asymmetric or toric scleral shape when we have a bigger lens, but there's some advantages of using a toric landing lens. The comfort improves slightly when you compare in one eye a symmetric landing versus the other eye a toric landing lens. We often have improved wearing time, meaning the patient's able to make it deeper into the day or longer into the day with better end of day comfort. The centration improves slightly, and what was surprising to our team at the university was that we have less blanching and less fogging with a toric landing scleral lens. So this is really the future. The beginnings of scleral lenses in the modern age were, all of them were available as a symmetric landing, but increasingly today, toric landing has become kind of the standard for the larger, greater than 15.5 millimeter lenses. Now, if you're new to sclerals, how would you tackle that first application and removal, and what fluids should we be using? And really, there's a fantastic video on the Scleral Lens Education Society website. It really covers everything that you need. So I'd encourage you to record www.sclerallens.org and look up this incredible video that Dr. Christine Sint created a few years back, and it covers almost everything that a patient should need to know related to the handling, the application, the removal, and it's great for practitioners as well that are new to scleral lenses. So make sure you have this available for your patients to view, and that'll really help them along, and it'll help your newer practitioners as well. Now, how do you choose the initial lens? And when we fit a keratoconic patient in the past with the corneal GP, it was like throwing darts at the dartboard. It was really confusing to know where to begin. What should I choose as my initial base curve? It might surprise you to know that with scleral, it's actually about as easy as it can get. Essentially, a scleral lens is given as a depth, or it's labeled according to its depth, or at least the ICD FlexFit is. So we know that eyes fall within a certain depth range. If you're fitting a normal cornea with ocular surface disease, you sure wouldn't expect that eye to be at the high end of sagittal depth. You wouldn't expect that eye to be deep. Whereas if you're fitting a keratoconic patient, of course you'd expect to need a higher depth lens. If you had a bulging graft, then of course you would expect to see a higher depth eye and therefore need a higher depth lens. And then going to the other end of the scale, if we had a oblated cornea, a post-refractive surgery eye, we'd expect to see a lower depth. So really, it's the condition that matters most and not K readings. So one of the considerations that you'll make first off is, am I dealing with a low asymmetry? Is this a post-LASIK patient? They tend to be lower in irregularity. They're actually quite straightforward as a scleral fit. If it's a high corneal astigmat, essentially a normal cornea, then they're a pretty easy eye. That's not a very asymmetric surface. Some of our emerging cones, they tend to be relatively easy, central cones especially. Then when you have your graft patients, that is often where you need a larger diameter. But there are cases where the graft patient has relatively low depth and a small eye. And in all of these cases, this is where we might use the smaller diameter 14/8. However, when the irregularity ramps up much higher, when you have a larger diameter eye as well, this is where you want to consider the 16/3. The vast majority of patients you'll fit are going to be in the 16/3 lens. The 14/8 will be a problem solver for you when you're running into smaller eyes, patients that are struggling with application and removal. It's really the lens that we go to second if the 16/3 has any issues. Now, there's another reason to consider diameter, and that's the visible iris diameter. So if you consider the visible iris diameter plus 3.5 millimeters, that gives you perspective on the minimum diameter that you could use. So as an example, if this eye is 10.5 millimeters plus 3.5, that's 14 millimeters, I can use as small as a 14 millimeter lens, most likely on that eye. Any amount larger is fine, but as a minimum diameter, 14 millimeters is probably as small as we could go to appropriately clear the limbus and the peripheral cornea. For your ultra large eyes, in this case a 13 millimeter visible iris diameter plus 3.5 millimeters, that would indicate that we need about a 16/5 lens. So if we put our 16/3 diagnostic on eye, we might not be surprised if it looks a little thin over the limbus or over the peripheral cornea, and therefore we may want to custom order slightly larger diameter lens. So you can always go larger than you think you need. Generally smaller gives you less vaulting over the limbus and peripheral cornea, and we want to protect the limbus and the peripheral cornea. Now, both the smaller diameter and the larger diameter share the same number of zones. There are 4 zones to consider, which we'll talk a little bit more about later, but suffice it to say that you don't have to think differently when you fit the 14/8 versus the 16/3, so that makes it kind of simple. There are, however, different markers on the 2 lenses. The 14/8 is a symmetric landing, and therefore it doesn't need toric markers. It does include these limbal clearance zone scribes, and what they're meant to define for you is the width of the limbal clearance zone, the LCZ. Now, what does that mean? We want the contact lens to clear through the limbal clearance zone. If these markers land within 100% within the borders of the visible iris, and you can see that here at around 11 o'clock, this marker is just reaching the border of the visible iris. And same with this marker at 1:30, it might be just past the limbus by a tiny amount. This diameter of lens may not be big enough. We would ideally like half the marker to be beyond the limbus 360 degrees around. So the marker helps you to determine when you need to go bigger or when you have the appropriate diameter of lens. If the marker is beyond the borders of the visible iris 360 degrees around, then we're happy. If at least 50% is beyond the limbus, then we're happy. If 100% of the marker is beyond the limbus, then we're really happy. Now with the 16/3, it includes the dual depth scribes, and what these define is the flat meridian of the lens, the meridian of least depth. They're most important to tell us if the lens is rotationally stable. We're more likely to need a front toric in the larger diameter lens, maybe because we fit more irregularity with the larger diameter lens. But in any case, if we need a front toric, our lens must be rotationally stable. So these markers need to position at the same axis on application as they do after an hour of settling time or beginning of the day, end of the day. So you can use those markers to determine, do I have a rotationally stable lens? Now, in choosing the initial diagnostic lens, I told you that it was quite straightforward, and really it is. If you're using the smaller diameter lens, if you have a normal cornea, let's say a astigmatic eye, then you would choose the 3400 micron height. If I were dealing with a very small eye that was keratoconic, then I would choose the 3800. Notice you're going up by 400 microns. If I were dealing with a small cornea that had a corneal transplant, then I would go up higher to the 42. So we know that normal corneas tend to be lowest in depth, keratoconic eyes tend to be higher. Transplants, they can be almost anything from low to high, but really it's always best to start higher than you think you need. If you put on a diagnostic lens that has too much depth, you don't necessarily have to put on another lens. If you put a diagnostic lens on that hits the central cornea, you must put on another diagnostic. So always better to go higher. Now, switching over to the 16:3, if we have a normal corneal height, if we have a normal eye shape that has ocular surface disease, we're going straight to the 4000 lens. If we have keratoconus, we're going to go to the 4400 lens. If we have a transplant, we're going to go up to the 4800 lens. So you'll notice there are 9 trial lenses in the 16:3. There's 5 trial lenses in the 14:8. If you find your demographic is a lot of small corneas, then you can also expand the set to include an additional 3 heights. But really, these 14 lenses should cover the vast majority of patients in most practices. Now, the lens is going to be applied with the bowl full of fluid, the patient 90 degrees to the plane of the floor, and we're applying the lens coming straight up. So we're going to want to trap all that fluid in there as we apply the lens. If the patient gets nervous, if they're a new contact lens wearer and they lose fixation as we apply the lens, then often a bubble will get dragged in there. So the lens needs to come off and be reapplied without the bubble. Because of course, if we've got this huge bubble in here, that's going to create a big dry spot. If you've got a few small little transient bubbles that are moving around, that is usually not an issue. But any bubble that's stationary, the lens needs to come off and be reapplied. Similarly, if you have a lens go on eye that has bearing on the central cornea, then you have inadequate depth. So we must put on a lens with a higher height. So how much higher should you go? And generally, if you put on a lens with touch, you need to be at least 400 microns higher. So just go to your trial set and reapply a lens higher in sagittal depth. So if we put on the 4000 micron lens, we can go up 400 microns from 4000 to 4400. Now, the lens thickness in both the small and the large, in all the ICD FlexFit lenses, is 0.3 millimeters thick. This is kind of the sweet spot for scleral lens thickness. Some are thinner, some are thicker. This seems to be right in the middle. It's a good balance of being thick enough to avoid flexing of the lens and induce astigmatism, but not so thick that it might reduce oxygen transmissibility. Now, you use this known thickness of lens, 300 microns, alongside your optic section to determine how much fluid is underneath the lens from center through the limbus. So in this case, if you know the lens is 300 microns, there's the anterior surface fluorescein, then the darker area, obviously the lens, then our posterior fluid filled with fluorescein, and then of course our cornea. So I would make out that in the center, we're pretty close to a 1-to-1 relationship. Maybe the fluid is slightly thinner than the 300 microns of the lens. But then going south to the area of the keratoconus, it looks like the fluid is slightly thinner, maybe 150 to 200 microns of fluid. So that's one of the ways that you can tell, do I have the right height of diagnostic lens for this eye? If you have a ocular coherence tomographer, then you can do a scan of the center and measure with the calipers the height or the apical clearance. Sometimes the instrument is in error. The OCT makes, let's say, capture errors. And it is always best to trust your optic section over your OCT. So when in doubt, always use the optic section as your tool to measure apical clearance. Now, when the lens goes on eye, it is going to begin this process of sinking and settling. It's going to start with lots of apical clearance, or it's going to start with whatever apical clearance it has, and then you're going to have less and less and less over the wearing period. And it is believed that that sinking and settling continues to happen over the entire day of wear. So in this case, we see a lens that goes on eye with 400 microns of fluid. After 30 minutes, we're down 60 microns. After an hour, we're still down 60 microns. After 2 hours, we're down 80 microns. After 4 hours, we're down 90. After 6 hours, 130. After 8 hours, 130. So in the course of the wearing of this lens, in this particular case, over an 8-hour period, 130 microns of apical clearance was lost. So be cognizant of that, because if you put on a lens with too little fluid, at the end of the day, that lens may well be in bearing with the cornea. And in a keratoconic patient with diseased tissue, we do not want our lens bearing on that area of disease. So our goal, at least at the university, is we would rather be higher than error on the lower side. Because of course, at the end of the day, you may not know how high that lens is above the surface. We may see the patient at the end of the day at 5 o'clock, but what is it going to be at 8, 9, 10 o'clock at night? Now there are 4 principal zones with the ICD FlexFit. Your central clearance zone, and it should do just that. It should clear the central corneal tissue. Then your next zone is the peripheral corneal clearance zone, or PCCZ, and it's meant to clear the peripheral cornea, of course. Then your third zone, your limbal clearance zone, LCZ, it should vault through the limbus. And then lastly, your scleral landing zone, the only point of the ICD FlexFit that should touch itself down. So you know from each one of these zones where the lens should be modified. If your lens is hitting the limbus, I know I need to modify the limbal clearance zone. If my lens is hitting farther in from the limbus on the peripheral cornea, then I need to modify the peripheral corneal clearance zone. If my lens is blanching, if it's tight at the edge, then of course I need to modify the scleral landing zone. Now, when you put on a lens, you will decide, do I need to increase or decrease the vault? So for instance, if we put a lens on with inadequate vault, with only 90 microns of apical clearance, and that lens was the 4,000 micron lens, I want to go up 200 microns. I want to have about 300 to 400 microns on application to allow for the average 125 microns of settling that may exist. So 300 to 400 on application to have approximately 200 to 300 after settling. If you prefer to have less vault, if you believe that there may be any concerns with oxygen permeability, then you can always go with less vault. It's really your choice how much fluid you want. Now, the way to modify the various zones is in the first zone, the central clearance zone, we can choose a higher or lower depth sagittal depth of diagnostic lens or of custom order, but you can also slightly fine-tune your custom order by changing the base curve. So in other words, if I use the standard trial lens with its associated base curve, and I want to increase the apical clearance a little bit, let's say 100 microns. If I steepen the base curve 2 diopters, every diopter of base curve change equals 50 microns. So if I steepen the base curve of my standard diagnostic lens sag, then I'm adding 100 microns of vault through the center. Conversely, if I flatten the base curve 2 diopters, I'm decreasing 100 microns from the apex. Now, this is important for those of you who are advanced scleral lens fitters. Notice that the base curve change only affects the center optic of the lens. Notice how the peripheral corneal clearance zone, limbal clearance zone, and scleral landing zone remain the same for all 3 of these lenses. When you change the base curve, you're not tightening up the entire fit of the lens. You are only altering the fluid thickness in the center. So that's how the ICD is much different from many other designs and certainly different from conventional lenses. If I had a corneal GP and I steepen the base curve, I would be tightening up the entire system of lens, the peripheral curves as well. Whereas with a scleral lens like the ICD FlexFit, if I change the base curve by itself, I'm not altering peripheral corneal vault, limbal vault, or the landing of the lens. Now, the second zone in the lens is best observed also in cobalt light. And here we're looking for the lens to clear the peripheral cornea, to show no point of bearing or landing on the mid-periphery and periphery of the cornea. Now, here's an example where we might have the standard trial lens vault over the surface. So there's edge on one side, edge on the other side, are vaulting through the apex in the middle. If I make the peripheral corneal clearance zone, the PCCZ or PCCZ, if I make it -4, 4 times 25 microns means we are shaving off 100 microns of vault through the center of the lens. If I were to make the PCCZ +4, I'm now adding 4 times 25 microns, I'm adding 100 microns of vault to the center. So every step that you alter the lens in the peripheral corneal clearance zone, the PCCZ, 1 step equals 25 microns. So plus PCCZ +1 is adding 25 microns of vault. PCCZ -1 is subtracting 25 microns of vault. So every step, 25 microns. But again, look at the periphery. When we change the peripheral corneal clearance zone, that alters what happens in the center 2 zones. It does not change the limbal vault. It does not change the scleral landing. So this modification is independent of the outer zones. Now, when we're most likely to modify the PCCZ is when you have a ultra oblate cornea, where you need the center of the lens to drop because you're dealing with that reverse geometry cornea. So this is where we might order a PCCZ -2 would be -50 microns, -4 would be -100 microns. Again, any minus adjustment, 1 step is 25 microns. Now, conversely, if you were dealing with the bulging graft like this, you may need that lens to share a similar high angle to the underlying surface. So that's where we may need to order a peripheral corneal clearance zone +5, sometimes +10, sometimes even higher than that on the extreme bulging graft. Now the next zone in the lens is your limbal clearance zone, and this is often best observed in white light to see the fluorescein run past the peripheral cornea, past the limbus, onto the sclera before it gets squeezed out. So here we're seeing a lens that looks like the fluorescein runs past the peripheral cornea and limbus 360 degrees around. This is really ideal. Now, when you see something like this, where the landing appears through the peripheral cornea and onto the limbus, this is a case where we need to modify the lens. Here, where we see the vaulting of the lens through the central cornea, mid-peripheral, peripheral, and limbus, we're happy with the vault. And that might look something like this in the OCT, where the lens clears cornea, clears peripheral cornea, clears through the limbus before it finally lands down. Now, the one that was confusing, at least to me in the beginning, was our lens that had partial thinning or partial bearing. And when you see less than 180 degrees of thinning, or what might be touch in the peripheral cornea or limbus, that often is benign. So if you're not sure, have the patient look in the opposite direction to the thinning. And if the lens skirts slightly nasal in this case, and it shows good vaulting through this area, if the patient looks down and the lens comes up slightly and shows good vaulting through the superior area, then chances are it's a non-issue. But the way you can be sure is to have the patient wear the lens for a number of hours, maybe 4 would be ideal or longer, and then have the patient remove the lens, or you remove the lens, stain the eye, and see if there's any signs of the lens being there. Is there any desiccation of the epithelium? If not, it's nothing to worry about. It's simply the decentration of the lens. Scleral lenses tend to ride temporal and inferior, and that thins out the fluid nasal superior. So you can't really do much about the decentration of sclerals. There's a lot of factors at work. The scleral shape promotes more temporal inferior displacement. The lid force is probably driving the lenses down slightly, and gravity is also pulling the lenses down as well. So inferior temporal is normal, but is it an issue with a bearing on the peripheral cornea or limbus? Is it an issue with the landing of the lens on the conj? Those would be some of the things we'd be concerned with if we didn't have the perfectly centered scleral lens. Now, to modify the limbal clearance zone, in a case like this, where the lens is laying itself down on the peripheral cornea and limbus, we need to increase the angle. We need to change the tangent of the lens. A plus adjustment is increasing the vault, is increasing that angle. Same as with the peripheral corneal clearance zone. Plus adjustments create more depth. Minus adjustments create less depth. Every step equals 25 microns. So if we had a lens that was indicating a bearing on the peripheral cornea and limbus, we would typically order a limbal clearance zone +5. We would increase this angle to get that lens off the eye surface. Quite a straightforward adjustment. This is not something you do in the diagnostic set. It's something that you call your consultant and have them modify in the lens. Now, the scleral landing zone is the final section of the lens where we're concerned about whether our touchdown point on the eye surface is acceptable. And in white light, we're observing 360 degrees around. Is there any restriction of the vessels running past the edge of the lens? Now, typically, if you have a lens that's showing some blanching or some whitening of the conjunctival epithelium, then that may be a case where the edge of the lens is diving into the surface. The angle of the landing zone is too tight for this patient's angle. This may be an eye that has a much lower scleral angle than what would be considered normal. We just simply need to increase that angle or increase the edge lift to match the landing of the lens to the angle of the underlying surface. Now, if you see a slight restriction in one single quadrant or clock hour, order scleral landing zone -1. If you see opposing points of restriction, order scleral landing zone -2. If you see 180 degrees of restriction, scleral landing zone -3. So mild, moderate, severe. There are cases when you may need even more, maybe 5 steps, but let this slit lamp prove that out. If you're seeing good vessel flow past the lens edge, but the OCT looks like it might be tight, I would let the slit lamp rule. It will be the ultimate decider for you. So very straightforward with scleral lens fitting. If we have a bubble or if we have any corneal bearing, we need to take that lens off. Apply it without the bubble, or if there's touch, apply a lens that is deeper, that will clear over that high point. When we put the lens on eye with the Fluorescein initially, it should be tough to make out eye anatomy like the pupil and the iris. So that tells us we've got lots of vault underneath the lens. When you have greater than 180 degrees of limbal bearing, that's something that needs to be modified. Let's order limbal clearance zone +5. If you have less than 180 degrees of that thinning in the peripheral cornea or limbus, normally it's a non-factor, but you might verify 100% by having the patient wear the lens a number of hours and then take it off, stain the cornea, and see if it's true bearing on the eye surface. Then the landing of the lens is one of those observations, just like the limbal vault, that's best observed after a period of settling time, minimum of about an hour. Now, what happens when you have residual astigmatism? How do we deal with that? And one of the things that you're going to do is, if you have an otherwise ideal fit, but we're manifesting cylinder over top of our scleral lens, then do K readings over top of the lens on eye or topography. If the anterior surface of your lens is coming up astigmatic, then you know the lens is flexing. Call your ICD FlexFit consultant and they will send you a custom order that's slightly thicker. Now that's if it's flexing. If it's not flexing, if the anterior surface is spherical, then we likely need to correct that internal sill. So we need to put on the larger 16:3 diagnostic lens and observe where are these dual depth markers and are they stable. Rotate the lens off axis, see if those markers come back to the same place. So what we do is put the lens on eye, we'll observe where those markers are after maybe 5 minutes of settling. Then we'll rotate them 90 degrees off axis, send the patient send the patient away for an hour. And then when they come back in for their post-settling analysis, we want to see if those markers have returned back to the same place. If the markers are rotationally stable, you know you can add the front toricity to the lens at its measured axis. So very often, the scribe marker axis can be at a completely different meridian than the over-refraction. Do not assume that the refractive axis and the scleral flat meridian will ever be the same. It's actually rare that the two line up with each other. So in other words, you might have the markers at axis 115, 335 degrees, but you record the cylinder at 90 degrees, for instance. So these markers are not meant to be at 0 or 180. They're meant to find the flat meridian of the sclera. And you will not know the flat meridian until that lens goes on eye and becomes rotationally stable. So these markers in the larger 16.3 are beneficial to help us with that front toric situation. If we don't have any residual cylinder to deal with, then really the markers aren't, it's not so important to worry about where they are and if they're rotationally stable, assuming the rest of the fit is without issue. Now, in terms of the landing of the lens, this is often the challenge that you face with scleral lenses, is creating an appropriate landing. Here we see blanching of the edge of the lens, and our OCT is showing us a lens that seems to be diving in at too high an angle. If you do exhaustive OCT analysis of the scleral angle, you may know ahead of time that the patient has a much flatter than average scleral angle, but most of us don't have the time to do that. So it's much quicker to put a diagnostic lens on eye and see if it settles in appropriately with a healthy landing. In this case, we can tell that our lens needs to have an altered scleral landing zone angle. And here we have the appropriate lens to surface relationship where the scleral landing zone is pointing along the surface, not into the surface, not above, not too much edge lift. So when you alter the lens, if it's the mildest adjustment, it would be scleral landing zone -1. And that might be if you have one little acute area of blanching. If you have a larger quadrant of blanching or opposing sides, then order a scleral landing zone -2. If you have greater than 180 degrees of blanching or a tight edge, then order scleral landing zone -3. Now, why is increased edge lift a minus adjustment? And that's really simple. If you take any contact lens you've ever fit and increase the edge lift of the lens, what does that do to the apical clearance? If you flatten the edge, you reduce the vault in the center. So in the ICD FlexFit, any adjustment to any of the zones that is minus decreases the central vault. Any adjustment that's plus increases the vault of the lens. So of course, if we increase the edge lift, we're decreasing the vault. A scleral landing zone -1, we're taking away 25 microns of height. Scleral landing zone -2, 2 times 25, we're taking away 50 microns of height. So that's how you can tell how much you're altering the depth of the lens with any of the zones. A -1, we're taking away 25 microns of vault in the center. Now, pinguiculas are rarely an issue in any other contact lens, but in scleral lenses, they have become more of an issue because we have this raised tissue that our edge of lens or our landing zone might be impinging on. So what do we do about the pinguiculas? What do we do about the filtering blebs that may be very close to our lens edge? And this may require some adjustment. Now, the 14.8 lens can be flexed down to a 14.5 to go inside of a bleb or a pinguicula. It can go larger up to a 15.5. So if, for instance, we're landing right in the middle of the pinguicula, we can oftentimes go larger and land just beyond it, or to just put mild pressure on the pinguicula. So you can go up or down in the ICD FlexFit. From the 14.8, you can go down to 14.5 or up to 15.5. With the 16.3, it can go down to 15.5 or up to 17 millimeters. Now, the reason why the diameter for each lens is within a specific range, it's because there's an algorithm that will adjust the apical clearance. So if I fit a 16.3 lens, but I order a 15.5, the apical clearance of the lens should remain uniform. In other words, I don't expect that if I order a smaller lens, it may hit the central cornea because it's lower in depth. So in other words, there is a smart algorithm that goes alongside this called the flex algorithm that will adjust for diameter changes to keep the apical clearance the same. Now, if we needed to go much smaller than 15.5, we could put on the 14.8 diagnostic, or your consultant could assist you with the calculation of the appropriate smaller diameter lens. Now, the ICD FlexFit is also available in a sector-specific landing, or what you might think of as a quadrant-specific landing. And every zone of the 4 zones can be lifted or dropped as required. And this can be helpful, especially in patients with pinguiculas, as an example, or asymmetric scleral surfaces. Really, this is a case where it's best to talk to the consultant. They can help you through this process of designing the appropriate lens. Now, what happens when you have an imperfect landing? You have a lack of rotational stability. You can't build your front toric for the eye. What happens if, after a successful application, the bubbles seem to be finding their way underneath the lens, creating an even bigger bubble after a very successful application? What happens if it's just one meridian that seems to have edge lift, but the other is tight? We may need to alter the landing of the lens, but how do you do that, and by how much? And this is where you might do what's called the Fluorescein test. That's where you take the lens off, rinse it off, then apply it without Fluorescein. So no Fluorescein underneath the lens, just your preservative-free saline. Then you can paint the anterior surface of the lens with a Fluorescein strip, have your slit lamp in position, focused, and ready to observe what happens with that Fluorescein. As it covers the surface, we want to know, does it find its way under the lens? Now, after a few seconds, we may be seeing some point of ingress of that Fluorescein. After a little more time, the Fluorescein is definitely finding its way in at around 11 o'clock and 5 o'clock. So when you do the Fluorescein test, it can tell you, do I have just one quadrant that needs adjustment? Do I have opposing quadrants? Is my toricity off? Do I lack the ability to keep the lens rotationally stable? Do I need to alter the landing of the lens? So this is a very important test to help you decide if I'm running into troubles with the landing or with bubbles getting in there, then where do I need to adjust it and how? So for instance, if we have the 16:3 lens on eye and we notice the dual depth markers are here, but the fluid is coming in 90 degrees opposite, that tells you that you have inadequate toricity. You need to increase the toricity of the lens. This is the steep meridian, and if the fluid is getting in under the steep meridian, we need more depth. We need a increased toricity. If the markers are here and the fluid is getting in on the flat meridian, that tells us that the lens is landing down too hard along the steep. It's actually lifting it off on the flat meridian. Therefore, we need to decrease the sagittal depth. In extreme cases, we may even notch the lens. Notching isn't preferred as a first step. The reason being, we want to have a very reproducible lens, and notching usually has to be done by hand, and that can't guarantee that you cut the same amount of material out of the lens. A second problem is if we notch too much, then that may break the seal as it lands on the eye surface and bubbles can get in. If you don't notch enough, of course, it's still going to impinge on a pinguicula, for instance. Notching can be very helpful, but again, I would not make that your first attempt at the lens. You might try changing the toricity or the asymmetry of the lens. Conjunctival prolapse is one of those complications that we see with scleral lenses. Thankfully, the pulling of that loose, foggy conj underneath the eye surface tends to be fairly benign. There are cases where it seems that the conj wants to anchor itself to the epithelium, and that the corneal epithelium, and that is definitely a case where we would want to modify. If you remove the lens and the conj immediately goes back to normal, that may be a case where it's not so much something you need to be concerned with. Now, how would we modify? And here's a good example where our lens is very close to the peripheral cornea and limbus on this side, but we're pulling conjunctiva under in the opposing side where the fluid layer is deepest. So if we decrease the limbal vault to allow less room in here for there to be this conjunctival prolapse, that may bear the lens harder on the peripheral cornea and limbus. So consider that you can alter the limbal clearance zone when you have the space to do that. So here's a good example. If you had lots of limbal vault, we could decrease the vault at the limbus and allow less room for the conjunctiva to be pulled under. So decrease the limbal vault in conjunctival prolapse when you've got the space to do it all the way around. When you don't, you may choose to go smaller in diameter. Give the lens less room to pull conjunctiva, fit a little closer to the limbus, and that is one of the ways that we can avoid having that conjunctival prolapse. Again, any of these complications, talk to the consultant. They can help you through this process. Now, the last complication I wanted to talk about tonight is fogging. It's one that is an idiosyncrasy of scleral lenses. When we apply the lens for a percentage of patients, they turn their posterior fluid layer into this foggy, milky, cloudy fluid, and that reduces the quality of VA. Now, in John Mountford's study out of Australia, he showed in the first 30 days of scleral lens wear, approximately 40% of patients had signs of fogging. But after 30 days, only 10% of patients had fogging. So expect that much of the fog may disappear the longer the patient wears the lens. And this study was done on a symmetric landing, not the newer ICD FlexFit that has the dual depth landing. We seem to have less fogging issues with the toric landing lenses. You can try applying the lens with preservative-free artificial tear. It's expensive, of course, but it's one of the things that seems to abate that buildup of fog. The second choice would be to build the lens with less apical clearance, and that is also a problem-solving technique. So obviously, using the preservative-free artificial tear is something that you can diagnose relatively quickly if it helps. To build the lens with lower apical clearance is a brand new lens. So a couple things that you can try. In the end, a percentage of your patients may be best to remove the lens midday, refresh the fluid, and then they're good till the end of the day. Numerous studies have showed midday removal of the lens just gives better all day long vision and comfort. Most of the patients are able to get by without having to remove the lens, so that's the good news. Now, there's a lot of things we talked about, a lot of modifications that are possible in a scleral lens, and it has to be because we're dealing with so many varied eye shapes. Don't be surprised if you need some assistance from the consultant. Use them as much as possible. Your Cardinal, your Precision, your ABB optical group consultant is there to assist. They are the experts in the lens construction. You are the experts in the eye. So help them through the process to appreciate what modifications need to be made. If you know the zone, is it central? Is it peripheral cornea? Is it limbal? Is it landing? What's happening with vision? These are the things that they need to know to best optimize the fit. But support is there. That's the most valuable thing you can know related to the fitting of scleral lenses. They can walk you through the entire process. So if you've never fit scleral lenses, these can really perform miracles for patients, especially with ocular surface disease, patients that are post-RK, they're struggling with consistent vision, your diseased eyes that the corneal GP just isn't able to manage the irregularity, comfort, centration, stability is an issue, fluctuating vision. These are all the patients that you might consider using a scleral lens like the ICD FlexFit. For those of you who are Canadian on this call, on this webinar, in Precision Technology and Cardinal Contact Lens have numerous products related to specialty lenses, corneal GPs, multifocal GP, orthokeratology, keratoconic fittings, scleral lenses, custom soft lenses, the Medmont corneal topographer, and support products for all. In the case of our American cousins who may be on this webinar, ABB Optical Group is probably the #1 company in the world with access to virtually every contact lens modality that's possible. So call your local distributor for support in anything specialty. If there's additional questions you have about fitting ICD lenses or irregular cornea, you might go to the YouTube, look up Precision Technology, the Precision Technology Services YouTube channel, and there's numerous videos on various topics from topography to corneal GP to scleral to help you through the process. And for those of you who are interested, there is a specialty contact lens symposium being organized for March 22nd, Sunday in 2020 in Vancouver, BC. And what's special about this event is the entire Pacific University contact lens faculty will be presenting on various specialty lens topics, from custom soft to corneal topography to corneal GP fitting to sclerals to myopia control. So it's a one-day conference that will be extremely hyper-focused on fitting the specialty contact lens and improving that component of your practice. So we welcome you there. I want to thank ABB Optical Group as a co-sponsor, as well as Cardinal and Precision in Canada. So your exclusive ICD FlexFit distributors are the ABB in the US, and in Canada, Cardinal and Precision. Everybody, thank you so much for logging into this session. We appreciate it and hope this has great value to you. We will follow up with an email with a video link to the session and answer any of your questions. Thank you very much and have a great evening.